and welcome to our live stream. I'm Dr. Ara Duke-Majan, CEO and founder of the Duke Spine Institute. We are going to be fixing a few discs in this patient. He presents to us with pain coming from what we believe is the L2-3 and the thoracic T9-T11, 10-11, correct?
Yes, sir.
T9-T10, 10-11. All right, just stay where you are. We're first going to access these discs using an X-ray and a needle. 5, 4, 3, 2, 2, 3. We all see 2, 3. Everyone agrees?
Yes, sir.
And shot. And his 2, 3 is from the left. We all agree?
Yes, sir. Left 2, 3.
All right. So there's the facet. He's got beautiful foramen. Look how nice the foramen is. 5, 4, 3, 2. Everyone agrees that's 2, 3, 3, 2. We're going to come in low within the foramen. Shot. I'm coming around the facet right now. And we're going to access the disc. Shot. I'm right at the back of the bone there. I want to be a little bit higher. Shot. So I'm coming in, adjusting my trajectory just a little bit. Shot. Whoa, shot. So that's breathing that did that. Shot. Oh, it's fascinating. I could actually feel a herniation right there. Don't really see it on the MRI. 5, 4, 3, 2. But that's where his pain was localized to. Okay. Let's get an AP. We're going to use navigation equipment called fluoroscope, which is actually an X-ray machine that can swivel and take pictures in different planes. Yeah, looks pretty damn good. So we're right at the disc in the back there. Want to adjust my trajectory just a little bit. Shot. Shot. All right. Shot. So this is the 2-3 disc. You can actually see the herniation right there. You see it, Jordan? Show us the herniation. See that curve right there? That is the herniation. And everyone agree this is 5, 4, 3, 2. 2, 3?
Yes, sir. Yes, sir.
So we are treating 2, 3. There is a tear there. I could feel it. All right, let's go down to the sacrum. Just check one more time. So, folks, we do a lot of checking for levels because, well, frankly, we don't want to operate on the wrong level. Just go down a smidgen so we can see the sacrum and verify. There's the sacrum. 5. Count 5. 5, 4, 3, 2. I think there's no doubt we're at the 2, 3 disc. Now we're going to keep going up with a lateral view. And I want to see 2, 3 at the bottom. There it is. You can go a little bit further. Shot. Oh, it's too much. Let's come south. All right, so we know that's 2, 3. So that must be 2. Show us 2. L2, L1, T12, T11. Just stay there at T11. Okay. So we know that's T11. And now we need to identify T9-T10, 10-11, correct?
Yes, sir.
Everyone agrees. So let's go up a smidgen so we can see 10-11. That's nice. Just go up a smidgen more. The smidgen of all smidgens. We just need to see the needle. Just the smallest amount. There we go. So now we know that that's L2, L1, 12, 11, 10. And we're doing 10, 11, right?
Yes, sir.
Everyone agrees? All right, we're doing it from my side, the right side, because I'm standing on the right side. So keep that view right there, and we're going to go for the 1011, and then we'll do the disc above that once we've accessed it. So this is one of the strategies we use in order to in order to make sure we're going to the right place in the spine. It's counting. We call that localization. All right, so there we go. So we know that's 2, 1, 12, 11. So I'm aiming for 11, 12. I need to aim for 10, 11. I need to be a little bit further up. Shot. That's better. Not perfect, but better. Shot. All right, so we know that's 2, 1, 12, 11, 10. I need to be a little bit higher. All right, let's get some num-num. Num-num is numbing medicine. It really makes it more comfortable for the patient and the anesthesiologist. And ultimately the surgeon. Helps with the vital signs, right? If patients aren't in pain, their vital signs stay stable. Shot. All right, so at this point, lateral. We're pretty close to that disc. 2, 1, 12, 11, 10. Let's go ahead and move north just a little bit. Okay, a little more. Shot. All right. Yeah, that's better. So you see how the end plates are coming into alignment there now that we move further north? Looking good. We're going to want to access that disc space. Yeah, Luis, I think this is a lumbar scope. So we're so far so good. Shot. I may be hitting the transverse process. We need to take a look at that. Let's go AP. So I'm going to use my X-ray machine and the bony anatomy of the spine to navigate to get to the tear in the back of the disc where the pain comes from. So I'm too medial. And by the way, look at that. I want you to understand something here. See where the needle is? That's number 11. And where's 12? Right there. Notice this patient does not have a rib at T12. This is a ribless T12. You don't see a lot of those. It's pretty rare. But if you use ribs to count, you'll get the wrong level. You have to use something reliable like the sacrum. And that's what we're doing. All right, back to a lateral view. So here's an example of somebody with 11 ribs instead of 12 ribs. And a lot of surgeons will make their determination in the thoracic spine as to what disc you're operating on based on the rib counting, but we cannot use rib counting here. All right. So Jordan, I want you to go north a smidge. Just a smidge. All right, I want you to put your arrow on that disc. And I can see a little beak. Look at that disc. It's fascinating. Look at the front. Look at the beak coming off the bone. That's a bone spur. That's an indication this disc is abnormal. And it's the one that we think is causing the pain. So stay there with the marker. Huh? Yeah, you guys are supposed to make sure the arm boards are as far north as you can. It's a team approach. Luis, honestly, you got to make sure the arm boards are as far north as possible, okay? It's not something we should be doing in the middle of surgery. Shot? Okay. All right, so little spawny. You're right, there's a millimeter or two, but not much. All right, at this point, please put the white arrow at the disc that you're targeting. Put it in the middle, right there. Just leave it there, okay? And don't move the fluoro. I'm going to move the needle. I'm going to come north just a little bit because I think I'm still a little bit too south by a few millimeters. And then shot. All right, very good. That's much better in my opinion. I think we're still too medial. And this is really just trial and error shot, going in and figuring out the best trajectory. See, I'm hitting his facets again. I need to get around this facet. Shot. Shot. Let's get another AP view. Lungs are good. Yeah, I'm just a millimeter. See that? We're touching the lateral margin of the facet. I'm so close to getting around it. So I always want to start medially and then work my way a little bit lateral to improve my trajectory. There we go. Shot. 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 So this is good. Shot. We're around it, like I said. Now, let's get one more AP and verify. At this point, remember, we have only 11 ribs, so it's gonna look like we're at 11-12 disc, but we're actually at 10-11 disc. So perfect. It's perfect. Look where the needle position is. Okay, Henry, are we live, by the way?
Yes, we are.
All right. You can see the needle is at the mid-pedicular line. This patient has huge discs. We're going to use with a larger scope to do his surgery. All right. So we're just about done here. I've got just placing this shot into the disc, and then we're going to do the next one. Shot. Now I feel a tear, by the way, a huge tear. AP, we're going to do an AP view. You getting all these views, Henry?
Yes, sir.
Perfect. All right, look at the needle tip. It's perfect. See the center of the spine? Yep. And it's almost at the center. So this is a really good trajectory. You always want to look at the lung fields. See the lung fields? You can see the lungs. There's no pneumothorax. You have to worry about that. Okay? It's a potential complication. So you want to check the lung fields. Go out a little bit towards me, my side, and take another picture. Further. You want to see the edge of the ribs. There you go. Further. Yeah, it looks good. There's no evidence of pneumothorax. Yep. You can see the markings, the lung markings, vascular markings going all the way. All right, so we've got 2 needles placed out of 3. We got 1 more to go. Any questions from the audience?
No current questions.
Do we have an audience?
Yes, we do.
All right, let's go ahead and show our video of, where's the num-num? Of this here?
Yes.
Our video of how do herniated discs, bulging discs, ruptured discs, protruding discs, how do all those things actually cause pain? Why are discs painful? We're just giving you some numbing medicine. And we're going to need them awake in about 10 minutes or less than 10 minutes once I get this final needle in. A little more numbing medicine, that's all. Okay. So, Henry, let's show our audience why do people get pain in their back from a herniated disc. I'm just giving you some more numbing medicine. All right.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. We are almost done placing needle number 2 while you guys were watching our video on how do discs cause so much pain. And the answer is it's inflammation. Inflammation. It's something that doctors ignore. You know, when I was a neurosurgery resident at University of Florida in Gainesville, I remember I was really impressed one day. Perfect. Look at that needle, it's perfect. So we got one at 10-11, and we're going to do the next one at the disc above 9-10. So perfect. Perfect position. So we were taking care of patients, and one day we had a patient come in, and he was in so much pain. Like literally, you just touch his back, and he would howl in pain. He was crying. He was a grown man. And we got an MRI, and what do you know? The entire disc was lit up like a light bulb. Okay, and that was my first time I ever saw a condition called discitis. And discitis is when your whole disc is full of inflammation. We're almost ready to do our, for him to be awake, Dr. Berndos. To do our, yeah, just lay still. Lay still. No, that's fine. We're done. I want him awake. You're doing great. You got an AP? So this patient had an MRI that showed the disc was super inflamed. And basically the most painful spine condition is discitis, inflammation of the disc. So when I remembered that, oh, perfect. I remembered that lesson as a resident about how discs could be so painful. And I started seeing patients over the years with back pain, and I went back to that lesson about how the disc could be so painful, because what everybody says about back pain is we don't know where it's coming from, we don't know where it's coming from. And I remember the disc can be very painful. Why aren't people looking at the disc? And that's when I started treating the back of the disc with the tear with the laser endoscopically many years ago. It's about 16 years ago now, and getting rid of the pain. And I realized this is an inflammatory problem, not a structural problem. It's not a compression of the nerve roots or spinal cord. This is an inflammation of the disc problem. And that's why Duke Spine is the first to document and a treatment specifically aimed at eliminating inflammation in the back of the disc where the tear is. Okay, are you comfortable? Are patients awake? Where's my marker?
He's awake.
Oh.
He's comfortable.
Are you comfy? I need an answer.
Yes or no? Okay.
All right. He doesn't have the face mask. His nasal cannula?
Both.
Oh. All right. How long have you had pain up here in your back? How many years?
35 years.
So thoracic pain, 35 years. Can you imagine having some problem like this for 35 years where you can't do anything because it hurts so bad? How long have you had the lower back pain?
How many years? 6 months.
6 months. So at least he's getting that fixed soon. 6 months. All right. Are you having any pain right now? Where? All right. All right. Just lay still. Are you comfortable? Don't move. Just touching the needle made him bad, huh? How bad is that on a scale of 1 to 10? How high does it go?
9.
Is that where you get your pain? Congratulations, we found one of your bad discs.
We're going to fix it.
That was your number 9-10. It was a 9 out of 10. It's concordant. That's the pain he typically gets. Is that better now? Don't move around so much. So I injected a little bit of dye in that disc, and just that little bit of dye, about a cc, has made him very uncomfortable. Lay still. That pain's going to be gone when we're done with your surgery. Lay still. How bad is that on a scale of 1 to 10? 10? Is that where you get pain typically? Congratulations, we found the second spot. That's the number T10-11, concordant. All right, easy, Tiger. You're good. We're going to put you to sleep in about 30 seconds. Okay? 30 seconds, you'll be asleep. I need your help for one more. How much pain is that causing? How much? On a scale of 1 to 10? 9.5. Is that where you get back pain? All right, you're going to go to sleep now. 9 1/2. All right, we'll do it for him. Concordant. That's L2-3. So L2-3 is a 9.5 concordant. T9-10 is a 9/10 concordant. And T10-11 is a 10/10 concordant. So we hit the bullseye, folks. This is the most advanced diagnostic and treatment you will see in the world today for back pain. This patient has lived with this pain for 35 years. He's had MRIs, x-rays. Nobody's figured out why he's suffering. All the doctors tell him there's nothing. We don't see anything. When you look at his MRI, which you guys are looking at right now at the bottom corner of your screen, you don't see anything. So all the doctors just blew him off, which is why he traveled from Texas. We got another Texan. He traveled from Texas to come here. And remember, Texas has the Texas Back Institute. That's just medicine going in your arm.
You're doing great.
Okay, that's the propofol. Lay still. Can you check his arms again? Make sure nothing's putting pressure on him. You're doing great, my friend. When you wake up, we'll be done. We're going to do everything through a 7mm incision. That's the whole surgery, 7mm. What do you got there? The reason why we do 7mm, let's show them the tube. Can you count out loud from 1 to 100? Okay. So we have two types of endoscopes. One is large, one is small. We use the large one for large discs. We use the small one for small discs. He's Texan. Texans, everything's big. Remember? Everything's bigger in Texas. So he's got big discs. We're going to use the bigger tube. But that said, the diameter of this tube is 7mm. Tape measure. Check this out. Put it down here. Sideways. All right, you guys see this? Look at this thing. 7mm. Okay? So the hole we make in the skin only needs to be 7mm wide. Shot. We're going to start with the thoracic, number T10-11. Shot. Guide wires in, needles out. Now, next step is dilator. It spreads the tissues. If you understand what I'm doing here, you'll understand why this is the only and best surgery in the world for you if you have a thoracic disc problem. We are spreading the tissues at this point. We are not cutting anything. We've already cut the skin. That's all we're going to cut this whole surgery. Shot? Okay. It's a little tight here on the skin. Let me have that 11 blade. I'm going to open up the skin because I think that the skin incision on the surface is 7mm, but down inside it's not. There we go. That should make it better. Let's have some num-num. So right now I'm bouncing on his fascia. You guys see this? Henry? Henry, move your arm, please. Henry, you see the bouncing?
Yes.
All right.
Yes, we do.
The top of the dilator is hitting the fascia. Fascia is a white membrane that covers your muscles. Okay? So I'm right on top of the fascia. And guess what? Fascia has nerves. It has pain nerves. So we're going to give a little pain medicine, and then I'm going to poke through the fascia. Shot. And I'm going to give him a little medicine in the muscle. Right there. I went through. I could feel it. Surgeons have to feel things. I don't know if you guys know that, but we're really good. Good surgeons are good at feeling. And what we're feeling are called tissue planes, P-L-A-N-E-S. What it means is we can feel the different tissues as we pass through them. And it's not something that's unique to me. All good surgeons are that way. I was taught that in residency. You need to be able to not just use your eyes, you have to use your fingers. Okay? And that's why when you do robotic surgery, the robot gives you feedback, resistance feedback to the tissues that the robot's feeling. That makes any sense? Why don't we do robotic surgery Why don't we do robotic spine surgery at Duke Spine Institute? Because robotic surgery is BS today. In 2023, the robots are there for one purpose, and that's to market and sell, but also to make venture capitalists super rich, okay? Because they're buying up these companies, and they're trying to go out and sell these robots and promote the idea of having a robot do your surgery. I don't know about you, but I would never let a robot touch my body in 2023. What you don't hear about are all the complications that robots have, okay? Lots of complications. They hide those from you because they don't want to scare the public, because the investors have invested billions of dollars buying these companies, and they expect a return on their investment, okay? And unfortunately, a lot of times patient outcomes, bad patient outcomes, gets in the way of making money. Well, at Duke Spine Institute, we want you to see everything we do, all of our outcomes, okay, good and bad, because we want you to make a good choice about what surgery you're going to have. Our surgeries are the best surgeries in the world. We're confident of that. That's why we show them to you live. Okay? Live, L-I-V-E. That's what we're doing today, live spine surgery. Yes, I'm hammering a tube in through their back into their spine. Why? Because we want you to see what's happening in real time. Okay, why? Because we believe in this technology so much, we're willing to share it with the world. Make up your own mind. Okay, robotic surgery, you'll never see a whole robotic surgery. Why? Because when they have a complication and the patient starts to die, they don't want you to see that. So they'll never show you live robotic surgery after surgery. Same thing with fusions. They don't want you to see exactly what happens with fusions. Now, we broadcast our fusions live at Duke Spine. You can go back and see our fusions for the last 10 years on YouTube. Every single one of them. As a matter of fact, I've done over 1,000 spinal fusions on the neck and 1,000 spinal fusions on the back in my career. I was born a spinal fusion surgeon, but I've evolved into an endoscopic surgeon because this is far better than fusion surgery. All right, any questions?
We have a couple comments. This first one comes from James on YouTube.
Hi, James on YouTube.
And they said, I will be submitting my MRI to see if I'm a candidate.
Wonderful, James. I love it. Thank you. Even if you're not a candidate, James, we'll give you answers. So the free MRI review is always worth it if you're wanting to know what's going on with my body, why am I having pain. Dr. Duke Majan will tell you. Duke Spine Institute will give you those answers. And it's free. We don't even charge you. Look at that. We're inside the disc. All right? What you're seeing there is the annulus fibrosus. And it's got some scar tissue in it. You've got the nucleus, which is blue. Now, normally the nucleus is white. It will not stain blue. So anything blue equals abnormal herniation. The reason it stains blue is because it's acidic. Oh, there's a piece of herniation right there, our first one. Lovely. You guys see that coming up?
Yes, we do.
All right. So definitely a herniation here. Yes, everything okay, guys? Yeah, we don't need you for 10 minutes. Another herniation. Wait, get a picture of this. Turn on the lights. You guys got to see this thing. You guys see this? It just came out?
Yes, we do.
Henry, you see this thing?
Yes, we do.
All right, bring the tape measure. Thank you, Luis. Put it right there. You guys see how big this thing is?
Yes, we do.
That is at least 1.5 centimeters long, and it's thick. That is a herniated disc. You couldn't even see it on the MRI. Everyone thinks MRI tells you everything. It doesn't. The doctor, a good doctor, will tell you what's going on. And there's very few of them in the world. Probably less than 10 in the world that can make the right diagnosis. All right, so there's one. Where's the other herniation? So far, we've taken out 2 pieces. Okay. Huh? You guys see the other one right there?
Yes, we do.
So 2 herniations. Okay. We're going to get some more. We'll get out however many he's got. This is why this poor man has been suffering. And nobody's helped him. Why? Because the doctors have no clue what's wrong with him. Duke Spine Institute, we're the best at making the diagnosis, and we're the best at fixing you. Look at the pink tissue, guys. This is brilliant. You guys see the pink? That's inflammation. So that herniation is right here, and there's inflammation associated with it. Another herniation. So it just herniations are coming out like gobstoppers. Very cool. This guy's going to do great. I'm so excited for him. You never know until you do the discogram whether or not someone's going to do well for sure. You know, you're using the MRI, you're using the clinical exam, x-rays, whatever, before surgery, but you never know until you do the discogram. Once you do the discogram and you see that disc is the cause of their pain, then you know for sure you're going to help them. You won't find this surgery anywhere else in the world but Duke Spine Institute. It's an outpatient, by the way. Where else can a thoracic disc herniation, 2 of them, be eliminated and repaired, and it's outpatient, where you go home an hour after your surgery? Nowhere else in the world, just Duke Spine Institute. We're the only ones treating thoracic disc herniations for pain. And there's nobody else in the world that does that. All the other spine surgeons, they have very invasive surgeries to treat this, and they won't do it because the risk of dying is at least 25% with the open invasive spine surgery, like fusion. So this endoscopic surgery we've been doing now for what, Luis, 3 years, 3.5 years now? We've done about 30 patients, maybe 35. The numbers aren't big, but they will be big in the future. But our average elimination of the pain is 99%. Okay, 99% of the pain coming from the disc is gone in our patients with this surgery. There's no surgery in the world that gives you as much pain relief as the Duke laser disc repair. And this is the only place you can get it, Duke Spine Institute, right now. Okay? We will be teaching other surgeons in the future. We will be expanding our facilities around the world. My gown is pulling apart in the back. Can somebody check that, please? Oh, there's another piece of herniation. So I feel it pulling apart in the back. Is everything okay? All right. So as long as that's fine. Any questions from the audience, Henry?
This next comment comes from Roosbe on YouTube.
I'm sorry, from who?
Roosbe?
Can you spell it?
Rouzbeh. I apologize if I pronounced that wrong.
Okay, Rosebeh.
And they said, "Hey, Dr. Duke, you wrote a note for me to attest to my C4 and C6 disease and to allow for me to get some added time for my Comlex level 2. I don't know if you remember, they are considering the note as inadequate evidence and are instead going by the radiologist notes. I have 2 radiologists and they interpreted my disc disease as mild, with the second radiologist interpreting it as even milder. I don't know who to go to as I don't think I can take the taste with the standard amount of time, which is what they're giving me. I'm still saving up for my surgery. As you said, radiologists don't know how to interpret disc bulges and just guess, and the NBOME is taking their word over yours, and you have a decade of surgery.
Wait. The MBOB?
NBOME.
I don't know what that is.
I don't know what that is either, but that's
All
what
right.
it says. And they said it's taking their word over yours, and you have over decades of surgical experience.
All right, well, first of all, nice to hear back from you. And I'm sorry you're having trouble with, it sounds like maybe your insurance company, I don't know. But it's very common for insurance companies to not want to pay for spine care. And I'll be honest with you, I don't blame them because a lot of spine treatments don't work. So they're probably just being very cautious about what they're willing to pay for and approve. That said, if I recommended the surgery for you at those discs, then that's what you need. Those discs are the cause of pain, and bulging discs do cause pain very often. You cannot, this is one of the biggest mistakes people make. They look at the herniation and they think that the bigger the herniation, the more pain you should have. But that is absolutely 1000% wrong. The size of the herniation, and by the way, a disc bulge is a herniation, it's just a small one. The size of the herniation has nothing to do with how painful it is. I want you to think about a rattlesnake. If you know what a rattlesnake is, it's a snake that has venom. A rattlesnake, big rattlesnakes, they don't have such good venom. But little baby rattlesnakes, small ones, they can kill you with their venom, okay, for several reasons. Number one, their venom's more potent, and number two, they inject more of it. So if you're going to get bitten by a rattlesnake, big is better than small, okay? So size is not the issue, it's the location of the tear and whether or not there's inflammation. A radiologist cannot tell you if an annular tear or herniation is causing pain. Only the patient can. So it's something we say all the time. Only the patient can tell you where the pain comes from. A good doctor can pick up on that and make a determination as to the source of the pain using the MRI and the physical exam. Great question, and I wish you best of luck. I hope you can get your surgery soon, and you need it. We can fix you. Next question, if there is one. We're just about done here, by the way. You can see the end plate right there. You can see another end plate over here. Those are the bones on the sides of the disc. We've taken out a lot of herniation. You can see just a little bit of this annular tear is left. A little herniation right there. I'm going to go grab it right now. But we've removed a lot of herniation from this T9-T11. Is that right, Louis? 1011? Yeah, 1011. I appreciate your questions and comments. Feel free to ask more. You're watching history, folks. Spine surgery history. Every time we do one of these thoracic endoscopic Duke laser disc repair procedures, you are literally watching the first of its kind in the world. And this is going to be the future of all spine surgery right here today at Duke Spine Institute. There's a piece of herniation there I need to get out. You guys see it?
Yes, we do.
It's just stubborn. A lot of these fragments of herniation are stuck down to the annular tear. You see where it's stuck down right there at the roof at 12 o'clock? There's a little attachment. That's scar tissue holding it there. So I use the laser to remove that scar tissue and loosen up the herniation, and I can pull it out. This one is not quite ready to come out, apparently. Maybe it is. Lots of little pieces. So whatever injury he had here in his lifetime, it was traumatic. It was really bad. And it happened, what, 35 years ago? 35 years. People live with this pain for 35 years. Why? Because their doctors and physical therapists and pain management docs all tell them basically not the truth. I don't want to say a lie, even though it is a lie. They tell them you can't get rid of it. You just have to do therapy, pills, shots, whatever it is they offer, obviously, right? So they're going to tell you need what they offer. But what they offer doesn't work. But here's the problem. The standard of care for spine pain has been nothing works. So let's just do all these treatments that don't work because nothing works, right? In other words, your treatment of not working is really not much different than my treatment of not working. The point is that there is a treatment that works. It's available at Duke Spine Institute exclusively at this time. And it is now the cure to back pain. So you don't have to do treatments that don't work anymore. I was having a conversation with somebody about treatments that don't work and how the insurance companies pay literally billions of dollars a year for treatments that don't work, and how they could save their money if they actually sent the patients to Duke Spine Institute for the right treatments. But again, the right treatment starts with the right diagnosis. It's always the first step. And we've mastered the diagnosis side just as we've mastered the treatment side. Any questions?
Yes, we additional comments and questions from Rosebeh on YouTube saying NBOME is the osteopathic NBME. And no, it's for my med school. They won't consider your note as evidence, and I just don't know what to do at this point. Do you think you can write me a note saying radiologists can't know this?
The neurologist can't know it?
Yeah, that's what they asked. Do you think you can write me a note saying radiologists can't know this?
Yeah, I mean, your insurance is just going to reject my notes, as we've already rejected it. What you really need is a lawyer. Okay, you need to sue your insurance company. That's the only language that insurance companies really understand, litigation. Okay, I'm telling you right now, we have a lot of patients that have the Duke laser disc repair, and they pay out of pocket for it, and then we have to go after their insurance. So there's not much else I can do, my friend. I wish there was, but I'm leading the fight, that's it, on this. But I don't know what your insurance exactly is, if it's like a Blue Cross or what, but eventually we're going to get insurance coverage. Okay, I mean, we do have a lot that cover, but it sounds like yours is not. We'll get consistent insurance coverage. What we're seeing here is the back of the disc, and we're outside the disc in the foramen. And I want you to take note. The annular tear that you're seeing there, let me have the laser. Remember, the inside of this tube, the outside of the tube is 7 millimeters. The inside of the tube is 5.5 millimeters. So that tear now needs to heal, but the good news is by removing the herniations out of it, it made the tear smaller. So that's a 1 millimeter wide fiber. So 1, 2, 3. About 3.5 millimeters is how wide the tear is now. Okay? But that will close off in about a year. It will be 100% healed. But his pain will be gone today. The pain that he came here with. And if I interview him, you'll see that the pain is gone today. We haven't done a lot of testimonials lately because honestly, I have been so busy with patients, treating patients, I haven't had time to go and take videos of the patients we're fixing. I know we have a lot of testimonials online and YouTube, hundreds, and I'll probably get back to it at some point. Lay still. He's a little too light. You're doing great. Lay still. Come on, Berndes. right. One down, two more to go. Any other questions?
No current questions, but we do have a couple comments from Canes25 on
Sure.
YouTube.
Fire away.
And they said the discogram is a phenomenal and crucial part of success. Nobody uses them anymore, and I feel they are so important in location of bad disc material. It's like traveling in the Amazon without a map. You are never without a map, sir.
You're right, and I appreciate your understanding of the value of that test. It's very important. Here's what's happening, folks. When the Nazis marched the Jews into the gas chambers, the first thing they did was they took away their weapons, they took away their families, and they separated them. They basically took everything away from them, okay? The insurance companies are doing the same thing to you guys, patients. They're taking away your MRIs, your x-rays, your discograms, your surgeries, your pain medications. They're taking it all away. Why? Because they want you to not cost them money. And when you do a discogram shot, it tells you, the surgeon, where your pain's coming from so they can treat it. But you see, treatment is expensive for them. Shot, it's surgery. Shot, they don't want to pay for your surgery. They don't want to spend the $80,000, $100,000. So they figured out that by not paying for your discograms, by bad-mouthing discograms, by not paying for your MRI shot, by not paying for your x-rays, they figured out that by doing all of that shot, that you can't have surgery to fix your problem if we don't know where the pain's coming from. So it's basically, they're stripping you, shot, of everything needed to get fixed, to get help, to get cured. They're stripping you of all the things you need to help yourself, okay? Just like, you know, the Nazis stripped the Jews of everything they could use to help themselves, just to avoid being slaughtered, okay? They're evil, 100% evil. There's no other reason except they don't want you to get medical care. They don't want you to be fixed. They want you to smoke marijuana and basically just die, but keep paying their premium. That's what they want, and that's what they're getting because people are doing nothing to fight them. Well, Duke Spine Institute is. We think that what they're doing is wrong, and we see what they're doing, and we're calling them on it. We're not just going to let you guys march off and die in pain. We're going to fight for you. And that's why I have a team that you guys don't know about, you don't hear about much, but they're billing experts, and they're a combination of billing experts and lawyers. And we're getting ready to take on the evil empire and fight for you guys so you can get your fixes that you need, the tests that you need, the treatments that you need, that you deserve, that you pay for. No human being should be left to suffer when suffering could be ended easily. And we now have a way to end suffering. But it's not available everywhere. So thank you for understanding the value of the diagnostic discogram. And you're right, the insurance companies are trying to bury it because if they successfully eliminate technologies that are helpful to patients, that open doors for treatment, then they want to close those doors so that you don't get the treatment because they don't want to pay for the treatment, okay? And it's a war going on, but it's a war going on without you knowing. Just like the Jews were led to the gas chambers without knowing they were being led to the gas chambers. It was a lie. They were lied to. And you're being lied to just the same way the Nazis lied to the Jews and exterminated millions of them, okay? What happened when the Nazis exterminated 9 million Jews? Well, what happened was easy. They took their land, they took their possessions, their belongings, their wealth, they took their history, their culture, and they took away They took away the need to feed them and clothe them in the winter. Okay? Those are expensive things to have to do. So the insurance companies are taking away the need to treat you. You understand? By eliminating the discograms and the MRIs, calling them experimental, unnecessary. And then they make us look bad. Like, oh, we're the bad doctor for ordering an experimental MRI. There's nothing experimental about an MRI, folks. It's just the insurance companies believe they can keep lying to the public and that they're never going to get caught. And it's time that the public wake up and realize they're being led to extermination by the most powerful, wealthy entity in the world, the insurance companies. Shot? Shot? Wow. That is a tough disc to get into. You're very scarred up. So we have one disc fixed, we have one thoracic disc fixed, we have one more to fix, and then we're going to go lumbar. I think that's pretty damn good right there. Maybe 1 more millimeter or 2. That's perfect. Thanks, Luis. Any more questions?
Yes, we have a question from Drim Builder on YouTube. Drim Builder
Yes.
asked, heard you say lay still, sir. Is he not sleeping?
Well, great question. So what is sleep? I don't know about you, but at 4:30 in the morning, I woke up, had to go to the bathroom. And then I went back to sleep. The point is that when we're sleeping, there are periods where we're more awake and periods where we're less awake. And I don't know if he can hear me or not, but if he's moving, whether it's reflex or whether it's conscious movement, I want to just have a reassuring voice that he can hear that commands him to do what I want him to do, which is to lay still. Okay? What we don't want is our patient to move around too much and fall off the table or, you know, have some kind of injury from the instruments we're putting in.
The last thing that's affected with anesthesia, sedation anesthesia, is hearing.
Yeah. So what Dr. Berndes said, which is fascinating, I didn't know this, he said hearing usually works in patients who are sedated. It's the last of your sensory organs to go to sleep, basically. So we like to talk to our patients in case they can hear us, reassure them, and tell them what we want them to do. But yes, the patient's asleep. It's just a matter of how deep asleep they are. And as you know, all sleep has stages, you know, 4 stages, and there's light sleep and there's heavy deep sleep.
It's all regulated by vital.
Yeah. And
Heart rate and tidal CO2.
that's right.
Breathing, it's all regulated.
It's all regulated by vital signs, Dr. Berndes says. Basically, the important thing to understand is if you put the patient too deep asleep, then they could stop breathing and die. We don't want that. And obviously, if they're too light, then they start moving a little bit or they respond. So we want to find, they have no recall. We want to find a nice balance where the
It's called a
patient,
plane, an anesthetic plane.
anesthetic plane. And just like an airplane, it goes up and down, right? But you're still in the airplane until you land and get out.
You have
So,
turbulence. It's interesting that you bring that up because if you look at all the medical professions, all the subspecialties, anesthesiologists own the most planes. They're the most actively enrolled in
pilot program.
planes, in pilot
That's
planes.
right.
Yeah, I just find that
What Dr. Berndes says is that he's the pilot and the patient is in the plane, his plane of anesthesia. And he's saying that he thinks that he should be a jet fighter pilot.
give me a disclaimer, I don't fly those planes.
He doesn't
Unless
fly
I'm a
real
passenger.
planes. Yeah. Well, anyway,
A lot of my colleagues do fly planes.
yeah, my wife won't let me fly a plane. I've tried. You know, I know that my wife will have enough of me when she tells me I can get a pilot's license. Right? All right. Any questions?
No current questions, but we do have a comment from Michelle on YouTube.
Hi, Michelle on YouTube. Welcome.
They said, I work in healthcare, and insurance companies are always looking to deny care.
Yep, you're right. They are always, and it's getting worse. So, Michelle, last night I found out that my mother-in-law is having problems with her vision from diabetes. So I called one of my friends, an ophthalmologist who actually has been in practice. He's a faculty. He's the head of retina specialist in Miami at Florida. Baskin Palmer. He's the head of Baskin Palmer.
What's his name?
Gupta, Dr. Shailesh Gupta. Okay. And he runs the residency program, everything. Anyway, we were talking yesterday. He's a retina specialist. And he was telling me that they're having more and more denials than ever before. And I'm like, retina, I mean, it's not like you're doing boob jobs, right? You're not doing elective spine surgeries like we are for pain. You're doing people losing their vision. They're going to basically lose their vision and go blind. And I asked him, how are things going? He says, getting worse. You know, a lot of denials from the insurance companies.
A lot of retina specialists that have a lot of emergencies. There's a lot.
Yeah. I said, how could you possibly get denials by the insurance companies? And he said, oh, it's getting worse. In the last 12 months, he said, it's gotten far worse. They're denying everything they can. These insurance companies are not regulated, and they need to be. Okay? They basically have a license to steal. You like that? A license to steal. They're stealing your money.
Look at them in Florida. They put you in a flood zone and a hurricane zone, and they don't look at the history. There's houses that have never been hit by a flood or a hurricane.
Let me have a grabber.
You know, since they've been built.
Oh,
And they charge like crazy.
Oh, yeah, they're charging ridiculous money
They're running.
for insurance of houses.
Yeah.
They need to be regulated.
I wrote a letter to the governor, but he didn't respond.
A letter to the governor. You think the governor is going to actually listen to you?
I wrote a letter.
We need to talk about your delusions of grandeur. Laser. Anyone who thinks the governor is going to listen to them, unless you're paying the governor, like, you know, you're donating to his campaign. I know Elvin is probably cringing over there right now. Is Elvin still around?
Yes, he is.
All right. He's probably got a smile on his face.
And you would be correct.
Yeah, we're almost done. 10 more minutes, we'll be done. So thank you for sharing your experience working in the healthcare industry, and I agree with you. It's horrible what's happening. I'm totally against it. If an insurance company wants to make profit by denying necessary medical care, just put that on your policy. You know, when you have your website, say, hey, Blue Cross Blue Shield, we're going to deny lots of care for our profits. So sign up with us if you don't mind getting denials for your treatments. Okay? Just be honest with people, and let's see how far you get with that. But the thing that bothers me the most is not that they deny your treatment, it's that they blame the doctors and say it's unnecessary, it's experimental. So by doing that, they're actually blaming us for the reason why they're not approving your treatment. They're making it sound like we've ordered an experimental treatment. Okay, and you're seeing this for everything now. MRIs. Since when is an MRI experimental? I mean, are you kidding me? They just, yeah, but the problem is there's nobody regulating them. Nobody's stopping them. There's no government agency because they own the government.
I'm naive. I did not know that they were doing that.
Oh, they do it all the time.
They call it MRI experimental.
Oh, they do it all the time. Experimental MRI, absolutely. If you have back pain and you go to your primary care doc, they won't even order an MRI because they know what's going to happen. It's going to be experimental. Their insurance company are getting away with everything. So bad. Wait. Hold on. Oh, look at that herniation that just popped out. That's crazy, grabber. There was nothing there a second ago, and now it's coming out. It's a good thing I looked. Oh yeah. Oh yeah, there's a few pieces down here. Nothing major, but thank you, Louis. Still want to jiggle it out if I can. Let's get the laser. Laser's far better than that. Anyway, this blue thing is a herniation. And there it goes. See how the laser releases it from the scar tissue that it's holding it in? Nice.
Other doctors criticize the laser. You have video proof on every
Yeah,
case
yeah.
how well it works, how effective it is. How easy it is.
Other doctors criticize the laser because they don't do the laser.
Don't know what they're doing.
They don't know what the hell they're doing. And they know they're losing business to the laser. They don't want to lose the business. They care more about their business than they do about their patients. That's the kind of doctors we're talking about here. All right, we're irrigating. We've completed treatment of 2 thoracic herniated discs, T9-10 and T10-11. You all agree? Thank you, Luis. Great job. Now we have 2 more surgeries after this, right? We have another thoracic, correct? And we have a, what, at the end? A lumbar? How many levels? 2? It's not that bad. My team has been working us to the bone lately. You like that, working us to the bone? As long as it's the spine bone. All right, questions, Henry?
No current questions, but we do have a comment from
I'll come to your side.
YouTube username Foxy Lady on YouTube.
Oh, Foxy Lady, what a great name.
And they said, I was told 4 months after I hurt my back a year and a half ago that I needed emergency surgery to do at T8-L1 fusion. I was scared to do the surgery, so I rejected it. I wish I could have your surgery.
Well, I don't know what's happening with your spine, but you can do a telemedicine with me, a Zoom call, and I will look at your MRI and I'll tell you what I think. You know, it costs you nothing, it's free, and you'll get your questions answered. Now, if you needed emergency surgery a few years ago, the chance that I can help you is probably 50-50, because the kind of things that people need emergency surgery for are things like fractures, unstable spine, tumors, infections, and I hope to God you didn't have any of those things, but obviously if you did, tumor, fracture, infection, I wouldn't be able to help you with my laser surgery, but I could do an open surgery if we needed to. Shot? Now the good news is, see this disc right here? It has a small tear, if anything. And shot? But it's definitely painful. So I think that this disc will be a pretty quick one to fix. I'm hoping. I probably just jinxed myself, but I'm thinking 10 minutes will be done, Dr. Berndes. Huh?
Thank you for telling me.
Yeah. Oh, I knew it. I didn't cut the skin properly. There's just a little tag that's caught. Shot. Yeah, skin knife. So the way I cut, I left a little bit of tissue deep along the shaft of the guide wire. There we go. Num. Shot. Nice. So we're going to put a little more numbing medicine. We call it num. We like to abbreviate things just because, well, to be honest with you, we have a lot to talk about. And if we didn't abbreviate so much, we would struggle. Hey, there's something wrong. Oh, what's that? Oh, this is plugged. This is plugged up. That's why I couldn't get it. Feel it?
Yeah.
Get it?
Yep.
Thank you. How is he doing? Good? Nice. All right. Any questions? Shot? So I'm in the foramen with the tip. I'm coming to I feel the herniation. I can tell you right now, this is a scarred up herniation, an old one. I know it's only been hurting him for 6 months, but I can feel scar tissue there. Any questions, Henry?
Yes, we have another question from, we have a question from James Mao, once more on YouTube. And they ask, Doctor, do you do kyphoplasty for loss of height from a compression fracture that shows 50% loss of height?
Yeah, we do kyphoplasty. And if you have 50% loss of height, we could definitely do a kyphoplasty. But, you know, the thing you really want to know, sir, is the kyphoplasty necessary? So the question really becomes, what does a kyphoplasty treat? It treats a fractured vertebral body or sacrum. And why would you do a kyphoplasty? You do it when the fracture doesn't heal on its own. So before I even recommended a kyphoplasty to you, I would want to know, do you need it? And the only way you're going to know if you need it is if you're actually having pain from the fracture. So a lot of fractures heal on their own and the pain goes away. And it may not be the fracture causing your pain, it may be a herniated disc above or below the fracture or your facet joints. You have a ray tech on the floor? So the most important thing is you need a diagnosis. I realize you have a fracture with 50% loss of height. That doesn't mean the fracture is the cause of your pain. I've seen many people with fractures in their spine where the fracture actually healed. They're not causing any pain, but the patient has pain, but it's coming from a disc or a facet joint. So my advice to you is do the pre-MRI review. Oh yeah, look at that. Degenerated nucleus. Fascinating. Remember, this was a 9.5, right, out of 10? This is all herniated disc. Degenerated, herniated. Inflammation is destroying it. Look how smooth that surface is on that piece. That's the work of inflammation. That's about 6 months worth of inflammation right there. And that's how old he said this herniation is. Laser, laser.
Thank you.
All right. Any questions?
No current questions.
Beautiful. All right. Well, so far so good. We got 10 minutes left and we'll be out of here on to number 3 for the day. This is a piece of herniation. Look at the calcification and scarring of that piece back there I was just working on. All right, looking good. See the tear right there, the blue thing between the white? That is the annular tear. That's what led to the herniation. Remember, you can't have a herniation without an annular tear. That's always the first step. Our new website will show you that. We have a nice animations that are coming. I've been working with a Swedish animator. And I've been working with a Swedish web team. We're going to be building our new website soon. It's going to be, I think, forget about what I think, all right? It is literally going to be the most advanced spine website in the world. It's going to have all factual information. It's going to all make sense. When you watch the site, you read it, you're going to be like, oh my God, this makes perfect sense. I understand it now. Of course, there will be the haters and the naysayers. Of course, there's always people that believe the earth is flat. I say, there are people that believe the earth is round. Flat earthers, right? So it doesn't matter how much proof you give them, they don't care. I'm not after those people. As far as I'm concerned, they can be miserable. the rest of their life. Thank God there's not many of them. They do call themselves the Democratic Party, though. I'm just kidding. I don't get political ever. I'm not going to start. But that said, the new website will be extremely informative, and it's going to have really nice animations that will show you in detail exactly why pain happens, how it happens, and what's really cool, we're going to have all these treatments that are being done by these doctors that shouldn't be done, like laminectomy, microdiscectomy, foraminotomy, fusion, artificial disc, interspinous device, intercept, barricade, disc seal, spinal cord stimulator. All those treatments are going to be on the website, and you're going to get to see exactly what's happening with those treatments in your body when you have one. You're going to get to see the destruction, the massive destruction of your muscles, your tissues, all underneath that incision, all hidden from your sight. But why do you think you're taking narcotics afterwards? Because basically a hand grenade went off inside your body during that surgery. How do I know? Because I'm one of those surgeons. I used to do them. And I did them really well, but there's still a hand grenade that goes off. So the Duke laser disc repair, we do this without hurting any of your body. It's just the skin incision, that's it. So that's why patients who have the surgery, they don't take narcotics after surgery, for the surgery, okay? They may come in on narcotics that their doctors put them on, wrongly so, and they'll go home on those and they'll taper off afterwards appropriately. But the surgeries we do don't create pain that requires any kind of narcotic painkillers, okay? Which is why it's great for military. By the way, you guys see that pink tissue right there? Right where the herniation, the blue meets the white? That is granulation tissue. That is the source of this patient's back pain, right there. We're going to go zap it away. The only way you can do that is if you have an endoscope. Without the endoscope, you wouldn't see that. There's no other microscope or tool or anything that lets you see it. Did you see it, Luis? That is the key to the success of our treatments, treating the source of pain. All right, any questions? 2 minutes.
No current questions, but we do have a comment from Trust saying,
Oh, Trust.
Trust on YouTube, they said, live surgery and answer questions. You are amazing. I have 100% confidence in you and your staff. Thank you for all you do.
Trust, I appreciate that. You've been with us for a long time. Thank you. And I appreciate you sending your family members to us for evaluation and care. And I promise we'll do our very best for everybody, but knowing that it's coming from you, I really appreciate that. Huh? Are you talking to me or somebody? All right, we got about 2 minutes left, Henry. We're going to be done. Remember, this was not a big tear. This is a small tear, but significant. Remember, the size of the tear, the size of the herniation doesn't matter. What matters is the symptoms that the patient experiences. Why do we practice medicine? We practice medicine to help patients, okay? Unfortunately, a lot of medicine is moved in the wrong way. It's now become practice medicine to help companies, to help insurance companies or help companies that make metal implants or spinal cord stimulators or any basically products, drugs. All these companies are trying to sell what they have. And honestly, they don't really care if it works or not. They just don't want any bad press. So if they kill a few people, that's okay. You know, that's their philosophy. Well, at Duke Spine, that's not our philosophy. We don't want anybody to be harmed by our treatments. We only want the best results possible. And so we don't actually use any implants because it's not necessary.
We have a question.
Yep.
This comes from Michael on YouTube.
Hello, Michael.
They asked, I have a herniated disc in the neck with arm weakness. Will this surgery help with the arm weakness?
Yes. Yes, Michael. Yeah, a herniated disc in your neck that pinches the nerve root that goes into your arm. Just so everybody understands, nerves, the nerves that we're talking about are called nerve roots. That's the part of the nerve that comes out of the holes in the spine in your neck or your lower back. You got 5 nerve roots that make up what's called the brachial plexus, which is a kind of a, I shouldn't say it, but like a, well, anastomosis. It's where a bunch of these nerve roots come together. Kind of like if you've ever seen some of those trees where their roots kind of come together and they kind of wrap around each other and form bigger roots, different roots. Anyway, that's what happens. So these 5 nerves come out of your spine. They go into your neck area right outside the spine, and they make what's called the brachial plexus, and then that breaks off in a bunch of nerves that go down your arm. So if you pinch your nerve root by the herniated disc in your neck, you're going to get arm weakness. And if that's what you have from a herniated disc, then this surgery is the perfect surgery for you, because we don't need to fuse you. We don't need to put a metal disc in. We can repair that disc better than a fusion and better than a artificial disc with less complications. As a matter of fact, we've never had a complication with the Duke laser disc repair on the neck in 16 years. We've never had a single complication. So it's safer, and the results are about 98% elimination of your pain in your neck. The weakness should go away as well. All right, just about done here. I'm surprised. Look at all the scar tissue. Couldn't tell based on the discogram, could we? The discogram and the MRI did not show any of this. The MRI showed none of it. Zippo, 0. Show them the MRI if you haven't already seen it. That disc looks almost normal. And I would never have known that this disc was the source of his pain just by looking at an MRI. So what I did was I did a physical exam. And my physical exam told me this is the disc causing his pain. Based on my physical, based on an x-ray that I took with a paper clip called the Duke x-ray test. We use it a lot for isolating back pain to a certain area of the spine. And that was developed at Duke Spine Institute. So I feel really good that he's going to do well. Any other questions? If you have questions, type them up. I'm going to come answer them for you, okay?
No current questions.
But we're pretty much done. And I couldn't have done this surgery without the laser. And I couldn't have done this surgery without my awesome team. No, I'm done. We're done. Yeah. Did you already spike it? Yeah, just switch it then. Might as well. Hey, it's okay. Don't worry about it. We're good. What's a bag of irrigation, right? Louise is looking at me like, oh, you have no idea how hard it is to get that stuff. Yeah, these supposed, what are they called? Shortages, right?
Yeah, no. We are good.
We're good. All right, we're done. Let's see if we can see the nerve. The nerve is going to be right there. But that's the nerve root. We're done. And the hole is about 3 millimeters. It's perfect. Type your questions up. I'll come answer them for you. This patient did really well. And we were able to fix everything we set out to fix. So I will say as summary that he has 1 less rib. Everybody has normally 12 ribs from T1 to T12. His T12 didn't have a rib. Threw us for a loop. This is clogged or something. And once we realized he had only 11 ribs, it all made sense. So, is he snoring?
Yes.
Sounds like he's snoring. That's good. He's happy. Type your questions up. I'll be there shortly to answer. We have 2 more surgeries today. The next patient is from Chicago, and he's having thoracic discs treated. He suffered with thoracic pain for many years in Chicago. Couldn't get any doctor to help him. Seen a lot of specialists. They all turned him away, said, we don't know what's wrong. We figured it out here at Duke Spine, doing some additional tests. And we're hoping that he's going to do very well with this treatment as well. So he'll be our next surgery. He's going to be a thoracic DLDR and a thoracic DPR. Anything else we're doing on him?
Yes, spinal cord.
Oh, we're removing a spinal cord stimulator. Yeah, if you want to see a spinal cord stimulator removed, we're doing that too. So to summarize the next patient, which will start in about 30 minutes, he's going to have two thoracic discs fixed and also have facet joints treated on the right. And then we're going to take a stimulator out. Now the stimulator, I want to tell you guys, stimulators are bad. Doctors are putting them in left and right.
Lights on, please.
They're putting them in because they're very profitable. They don't help the patients. They rarely help the patients. But then again, remember, the problem with spine care is that all the treatments barely help the patients at all. So if you're going to do anything, you know, maybe you have a 20% chance of helping, you might as well, these people are thinking, might as well put a stimulator in, make some money, even though it's probably not going to help the patient, like every other treatment doesn't help. You understand? So the problem is this apathy, this apathetic belief that there's really no way to fix back pain anyway, so we might as well use the patient as a guinea pig to extort money out of insurance companies. That's kind of the situation we're in. And this guy had a stimulator put in. It didn't help him. The trial helped a little bit, but what they do in the trial is they'll give you some steroids. So it seems like it's helping. It's a trick. And then you say, yeah, I'm doing a lot better. And then they say, okay, good, he passed, he got better. That justifies to the insurance company that we can put a stimulator in. The profit on a stimulator is around $10,000 to $20,000 per stimulator. And the doctors that put them in used to make profit of $50. Now they're making $10,000, $20,000. So we have all these venture capitalists coming in and buying up surgery centers for pain management, and then, you know, riding those pain management doctors like Seabiscuit, you know, whipping, cracking them. Hey, do some more stimulators. So if you look at the pain management surgery centers these days for spine, they'll have 10 or 20 spinal cord stimulators in a day. They're making $400,000, you know, to $1 million in a week. And they're basically just putting these things in left and right. And it's unethical, it's immoral, it's unconscionable, especially when there's treatments that actually cure pain. All right, write your questions up. I'll be there in a few minutes. Henry, you want to cut to a testimonial?
Good morning, I'm Dr. Duke Majan. It is March 1st, 2023. I'm here with a patient who traveled to Florida from Iowa. He has been suffering with back pain for years. He started to have leg symptoms in his left leg. That lasted for a few years. Then it switched to the right leg, right?
Correct, yep.
And you said, enough is enough, I need to get this fixed. And yesterday you had the Duke laser disc repair, which is the endoscopic surgery with the laser repairing the damaged discs in your back. And you're here today, less than 24 hours after surgery. How do you feel?
It's almost unbelievable. And I'm typically kind of a skeptical person. So it's like, okay, something doesn't seem quite right, because I have no pain. I took no pain medicine. You know, went from my left, which I had for multiple years, and then it went to my right and went down, made the outside of my calf numb. I can't wiggle my toes, and my foot wanted to roll. And we had the surgery, and I woke up and felt great. And then, you know, I got up in recovery and walked around, and I could already tell my foot wasn't wanting to flop and roll. Now I still have a, you know, and even on the left, I had some sensation here that's, you know, was kind of numbing, and it's starting to come back. Mm-hmm. Again, I'm skeptical. It's like, okay, how much is this as placebo? You know, because I was telling Dr. Duke that I don't get it, because, you know, he cut my back, he pounded a rod in there, did 4 different levels, and I have no pain. It's just incredible.
Yeah, it is incredible. That's why we're trying to share these stories with the rest of the world, so people could stop living with the problem or stop having bad spine surgery elsewhere.
Yep. And I went back to the hotel and walked around the outside of the building probably 4 or 5 times. And typically I would start feeling some back tension then. Nothing.
Yeah, it's gone.
It's gone.
It will be gone for the rest of your life as long as you don't re-injure it. Let it heal. Yeah, he woke up yesterday and I came to visit him in the recovery area, and the first thing he said is, "This is amazing, but it must be the medicine, right?" And I said, "No, we haven't given you any medicine that would do that. The propofol we give, which is the sedative for the surgery, it's not a painkiller. It only puts you to sleep. So you'll still feel pain even with the propofol." Basically, the results are legitimate and genuine. And that's what our patients experience with this procedure.
It's amazing.
So what did the back pain and leg symptoms, how did it restrict your quality of life? Tell us a little bit about that.
Oh, again, over the years, it would kind of, I'd hurt and I'd have to lay down and not do much. And then here towards the end, I couldn't walk very well. I mean, and luckily my job is, an IT job, so there's not a lot of walking. So I was still able to do my job fine, because if I would sit, it would be okay, not a lot of pain. But I couldn't walk, and the foot would flop when I'm trying to walk. It's just incredible.
Yeah, no, I appreciate that. And so it really had an impact on your work, but also your hobbies, I'm sure. It restricted your quality of life with your spouse, who's here, and loyal wife who's here supporting you. I'm sure she suffered with you. I could see it on her face.
Yeah.
Right?
Yep.
It's hard on people when you have a medical problem that you can't find an answer to. Now, were you offered other surgeries for your back?
Oh, yeah, I guess, I did some research. I actually went to, and I probably can't name them here, but I went to 3 different spine surgeons before I talked to you. And 2 of them recommended a 3 or 4 level fusion, and 1 of them recommended that I don't think we can do anything for you, so I wouldn't do anything.
And that's a problem, right?
Oh, yeah.
Because that's not accurate.
I'm convinced that if I wouldn't have done something, I wouldn't be able to walk very well at all, in a pretty short order of time.
Yeah, you would be wheelchair bound. There's no doubt about it. So isn't it surprising that there are doctors who cannot figure out what's wrong?
Yeah, I don't understand.
Well, I've had many network administrators and IT people working for me over the years, and I've seen many of them that can't figure out what's wrong. And many of them that do bad patch jobs, right? Same thing with back surgery. You're gonna have doctors who don't know what to do at all and throw their hands up and say, live with it or go to pain management. You're gonna have those doctors who think they can fix it and will give you the type of treatments that really are not good treatments. They don't last or they don't work properly. And then you have, once in a while, you find someone who really understands what they're doing and can give you the very best solution in the world. And I know I would pay anything for that myself. I would just ask, how do you feel today? And is there anything you want to tell the rest of the world out there?
I feel great today, and one of the things I've always said is, as you go through your working career, I've worked with a lot of people that said, when I retire, I'm going to go do this, I'm going to go do that, and something happens, and they don't get to do the things they dreamed about doing. I feel like I'm going to be able to do the things that I want to do.
Yes, you are.
So I would say anybody that's having back problems, come see Dr. Duke.
Well, thank you
For
very
sure.
much. I appreciate that. It's great helping you and your family. Take
Thank you.
care. And don't do too much too
I won't.
soon. All right. Dr. Duke Machen, and I hope you enjoyed that testimonial as much as I did. That was a patient who we helped get out of pain here at Duke Spine Institute. So we've just wrapped up a patient who traveled from Texas. He's had back pain in the lower back, not down at L4-551 by any means, but around L2-3, and then again in the thoracic around T9-10-11. He came to us, honestly, wasn't planning on doing surgery on him. He came here from Texas, just came in as a patient with his wife and said, "Fix me, Dr. Duke." And so we first started by looking at the MRIs, and I could see right away, looking at his MRI, I could not tell where the pain was coming from. His herniations, if anything, they were tiny. They were real small. So there was no nerve root pressure. He wasn't having leg symptoms at all. It was all right in the back, in the thoracic and the lumbar. So I really had to put my thinking cap on. And one of the things we've been doing at Duke Spine lately that is amazing
is we'll have our patients point exactly where their pain is, and then I put a paper clip and tape it on their back, and we do an x-ray. And we do the front x-ray, and you can actually see exactly which disc that paper clip is at. And it works amazingly well, because where you tape it on the back is so close to the spine and the disc that you can see right through the disc where the paper clip is, and you know which one it is, you just count. So we did that for this patient. We also got a new MRI on him, and looked and things, and of course we got thrown off by the fact he has 11 instead of 12 ribs, so that threw us for a brief momentary loop until we figured that out, and then ultimately through a little Sherlock Holmesing, we figured out where the pain was coming from. It was not the facet joints. That would be the other option, facet pain. He had no tenderness over his facet joints. He had no lateral pain. It was all center, so that's disc. He had no fracture, no tumors, no infection, so that eliminated those things. He was left with a disc problem, which is the most common cause of back pain anyway. So we just had to figure out which disc it was, and we did. We just tested those discs, and sure enough, they're painful. Like one was a 9 out of 10, 10 out of 10, and then 9.5 out of 10. So basically an average of 9.5 out of 10, which is really 10 out of 10. Yeah. And more importantly, it was all concordant. It's his typical pain he gets every day, so it's not like we were creating a new pain that he didn't have before. So I feel really good. He's going to do well. I think he's going to leave here happy. And that's what matters. And Duke Spine does that better than any other place in the world. All right, any questions?
No current questions.
Thanks for joining us. We'll be back in about 30 minutes with our next surgery. Like I said, the next patient's from Chicago, and he's been suffering with thoracic pain for years. His doctors did shots and therapy and all kinds of treatments that didn't work. Eventually they just said, let's put a spinal cord stimulator in. Cha-ching, cha-ching, cha-ching. It may help you, but it really won't. It'll help us, we'll make lots of money. So they stuck a stimulator in him, and of course it didn't do anything for him. And worst of all, they use round leads. When you use a round lead stimulator, you're basically tapping out before you start. No, round lead stimulators don't work worth shit, okay? You want a stimulator that has a chance of working, you need a paddle lead. Paddle leads are better. They stuck round leads. Round leads are cheaper. Profit margins are higher. So just this whole thing smelled and reeked of, mismanagement for the benefit of the doctor rather than the patient. We see this a lot, about 1 million times a year, and we're just trying to make you guys aware of the scams and pranks and snares that you want to try to avoid in getting your back and neck fixed. Duke Spine doesn't do dishonorable things. You can come here and trust that we're going to do what's best for you. All right, hope you enjoyed the broadcast. We'll be back in 30 minutes.